A very good day to everyone. My name is Dr. Tanvi, and the topic of my presentation is retropupillary iris claw lenses versus scleral fixated lenses using Gore-Tex in children with large lens subluxation. So the management of subluxated lenses varies from optical correction in low grades of subluxation to the removal of the lens and intraocular implantation in higher grades. The IOS that we implant can either be anterior chamber IOLs, iris claw IOLs, or scleral fixated IOLs, which could either be sutured or sutureless. The sutures that we use can either be 10-0 Prolene, 9-0 Prolene, or Gore-Tex. At present, there is paucity of literature which documents the safety of Gore-Tex in pediatric eyes. Also, there is no consensus on which of these techniques is the best for early visual rehabilitation in children. So we undertook this study to compare the functional outcome of retropupillary IOLs and sutured SF IOLs in children with subluxated lenses and to compare the IOL tilt in the two groups. So this study was conducted in 60 eyes over a duration of 1.5 years. The patients were randomly divided into two groups. Group A underwent retropupillary implantation and Group B underwent SF IOL implantation. The primary outcome that we measured was the best corrected visual acuity in logMAR, and the secondary outcome that we measured were the assessment of the IOL tilt, mean change in astigmatism, and the mean operating time. We included patients in the age group of 6 to 18 years with ectopia lentis of more than 7 clock hours, and excluded patients with any gross anterior or posterior segment pathology or trauma. So the surgical technique in Group A involved marking of the horizontal meridian, followed by a pars plana lensectomy and vitrectomy. This was the iris claw IOL that we used, and the arrow shows the claw mechanism into which the iris tissue was enclaved. After the creation of a superior clear corneal incision, the retropupillary IOL was inserted into the anterior chamber along its shortest diameter. It was held with a lens holding forceps and slipped posterior to the iris. It was then enclaved into the mid-peripheral portion of the iris. We can see the result at the end of the surgery, showing pupil ovalization and a patent iridectomy. The surgical technique in Group B involved marking of the horizontal meridian, followed by the creation of 4 pars plana ports, 2 on either side. These ports were created 5 mm apart and 3 mm from the limbus. This was the SF IOL that we used, showing 4 eyelets. So the Gore-Tex suture was cut into half, and each half was threaded through the adjacent eyelets of the SF IOL. After the insertion of the IOL into the anterior chamber, each of these ends were then externalized through the respective sclerotomies. And this was the result at the end of the surgery. So we observed at the end of 1.5 years, the mean BCVA in Group B was better as compared to Group A. However, it was not a statistically significant difference. We measured the IOL tilt by a method described by Loya et al., in which in the UBM, we measured the distance from the iris pigment epithelium to the anterior surface of the IOL, superiorly and inferiorly for the vertical meridian, and nasally and temporally for the horizontal meridian. If we found the difference between the two to be more than 100 microns, it was considered to be a significant tilt for that particular meridian. So we noted that Group B had a higher number of significant tilts as compared to Group A, but that was not a statistically significant difference. The change in the astigmatism from the preoperative to the postoperative values in each of the individual groups was statistically significant because of the elimination of the lenticular astigmatism. However, at the end of 1.5 years, both the groups were comparable. And there was a statistically significant difference between the two groups in terms of the mean operating time, with Group B having a mean operating time of 90 minutes and Group A having an operating time of 40 minutes. So this was a patient of clear lens subluxation who underwent retropupillary implantation. As we can see here, these are the enclavation sites of the retropupillary IOL, and the IOL appears to be well centered clinically as well as on UBM. This was a patient of cataractous subluxated lens who underwent SF IOL implantation. Here the IOL appears to be well centered clinically as well as on UBM. So if we compare and contrast retropupillary IOLs and SF IOLs, retropupillary IOLs are associated with complications like spontaneous disenclavation, pupil ovalization, which is not vision threatening, and in the long term pigment dispersion and secondary glaucoma. On the other hand, SF IOLs are associated with increased manipulation at the vitreous base, therefore complications like retinal detachment, suprachoroidal hemorrhage. Also, they are associated with suture-related complications like suture breakage, erosion, degradation, leading to long-term IOL dislocations. If we compare the advantages, retropupillary IOLs are technically simpler with lesser complications, and therefore they have an early visual recovery. SF IOLs, on the other hand, are a time-tested method, and they're not dependent on the integrity of the iris tissue. Therefore, they can be safely implanted in conditions like traumatic mydriasis and aniridia. So I'd like to conclude that both the techniques provide good visual rehabilitation in children with large lens subluxations. However, retropupillary being technically simpler, we recommend it in subjects with high risk of retinal detachment like Marfan syndrome, myopia, and peripheral retinal degenerations. Thank you.
And I think there will be no questions on your keynote address. So with that, thank you so much.